It's time for Health Futures with Cypress Home Care Solutions, Bob Roth. This is Arizona's only show dedicated to providing you with expert advice on how to live a longer, healthier, and happier life. To learn more, call 602-264-8009. That's 602-264-8009. Now, here's your host, Bob Roth.
Good afternoon. You're listening to Health Futures, Taking Stock in You. I'm your host, Bob Roth, and it must be Friday, and indeed it is. I cannot believe it is the 1st of September. Big birthday month for me, but hopefully it is the beginning of some cooler weather here in Phoenix, Arizona. If this is the first time you've tuned into our show is about how our older adult population can live a healthier, happier life. And how do they do that? They do that by listening here at Health Futures on Money Radio, 1510 AM, 105.3 FM, and the World Wide Web, moneyradio1510.com. I am really pleased to have this guest here in the studio with me. I cannot believe it's been 4 years. How could that be? But without further ado, let me introduce you to Dr. Alicia Mangram. She's a trauma surgeon and founder and CEO of G60 Trauma. Welcome to the show.
Thanks, Bob. Good to see you again.
It's good to see you again. You're looking good, and the last time I saw you was before this pandemic happened.
Yes.
It seems like you were here yesterday. It really does.
I know. Time flies.
And a lot has, I'm sure, happened in your life since that time, and a lot has happened in our lives as well. So welcome back to Health Futures. It's great to have you.
Well, thank you so much for having me back.
You know,
I appreciate that.
And it's funny. I hope you don't mind me sharing with the audience. You and I crossed paths last year, and you and I both practice yoga. And yoga is an incredible thing for me. I feel like it's helped me both physically and spiritually. And
yeah, I love it. It was very interesting because usually in yoga, you're quiet, your eyes are closed, you're relaxed, and you're breathing and focused on your breathing. But I just kept peeking out of the corner of my eye. Don't I know this man over here? And it turned out it was you. So it was just so nice to see you there. And yes, I still practice yoga. I went to hot yoga, believe it or not, last weekend. And it's funny because I walked out and it was hotter outside than it was in hot yoga.
Isn't it crazy?
That's just crazy.
But it, you know what? Getting through it sometimes is so hard. But once you're done,
yes,
it feels so good.
It does.
It really does. And certainly, as I shared at the top of the show, it's a birthday month for me, and I'm always sharing my story and certainly self-deprecating at times. 61. It's hard to believe, but in order to stay in shape, I need to do yoga. I need to do other things. I need to move. I need to eat better.
Well, you'll be surprised. It was a birthday month for me, except it's September now, right?
Yes, it's September.
Mine was August. So we're both Virgos.
There you go.
We both just had our birthday month, and I feel the same way. As we get older, we can't do everything we used to do, but there's some things once you find something, biking, yoga, walking, even hiking you can still do. I made the silly move that I wanted to climb up to the top of Camelback probably about 7 months ago, and I did it.
You did?
I did it. And
Congratulations.
It was actually easier going up than coming down, but I won't do it again.
No, but what's interesting, and I hope you don't mind me sharing this,
Yes.
you shared this with me when I saw you in yoga. Mm-hmm. You had a hip or knee done, right?
I had my hip replaced.
Yeah, and you hiked Camelback Mountain with a hip replacement.
I did hike it.
And pain? No?
No.
Yeah.
I feel great from that. I'm glad I did. I should have did it 10 years ago. I had a little, of course there was some arthritis there, but I also had what they call angiodysplasia of the hip.
Uh-huh.
So I had one doctor say, you should have did this 10 years ago, 20 years ago. But I'm glad it's done.
Well, I'm glad you had it done, and you're able to move and do things that you were able to do prior, and certainly
better.
prior to you had the pain. Yes. And better.
Yes.
And you're an advocate of getting that stuff done when you need to have it done.
Get it done. Don't wait. What are you waiting for?
Well, you know what? I really, it's hard to believe it's been 4 years. And, you're not only a trauma surgeon, but you are a founder of this G60 trauma. And, certainly want to tee this up so our listeners know a little bit about that G60 trauma.
Sure.
It's a not-for-profit, right?
It's a non-for-profit. It's kind of changed. I mean, we still have a G60 program, but well, let me give some background. So we started G60. I said it probably the last time we were on the show, really back in 2007-8, and it basically is just a program that's inside of a hospital, and a hospital that's a trauma center, and the whole purpose of G60 is to provide care that's a little more expedient, with a more sense of urgency, and to get the patients in and out of the hospital quicker. And basically, we were learning at that time, back in 2007, and I started the G60 program here in 2011. The focus was get those patients to the operating room quickly and get them out of the hospital quickly. Don't let them be the last case at the end of your busy elective week. Let's really work and focus on moving them in a different direction and change the way we think. So all of really G60 is a mind change. It's getting trauma surgeons and hospitalists and general surgeons to realize that 60 now is not 60 then. I had this sort of, my little theme is 60's the new 40, 70's the new 50, 80's the new 60. And that was the theme when we started it.
Wow.
And it's still the theme, because if you think about it, like I said, I hiked up, camelback. You go to yoga every morning at 6 a.m. In my neighborhood, you need to be more worried about the people riding the bikes than people driving cars, because everybody's riding their bikes. And the majority of them are older. They're probably 50, 60, 70. I'd even guess 80.
Right.
Yeah.
And I don't think I realized that's how you came up with the name G60.
Yeah.
So, and certainly older adults are something that you see. And Dr. Mangram, are you okay if I call you Alicia?
Please call me Alicia.
So, Alicia, one of the things that I remember you talking about, and I saw you in a public forum, and you were, speaking from the podium, you were talking about the trauma that is happening to older adults, and you were comparing it to automobile accidents. I mean, I can't imagine as a trauma surgeon all the things that you've seen. And I first of all, you must be an adrenaline junkie. You have to be. I mean, it's like, all hands on deck. We gotta roll up our sleeves. Let's get her done.
That's right. Right.
But I mean, I remember you telling me that these falls that people were having 60 and older were like these horrible automobile wrecks.
Yeah.
Can you expand on that a little bit?
So it's what's interesting about trauma's changed so much. People that went into trauma, like me, the adrenaline junkie, we were used to gunshot wounds and stab wounds, and a normal trauma would be, we have a 20-year-old shotgun wound. You get them, you run them up to the OR, fix their spleen or take it out, fix their liver, do whatever you need to do to their intestines. They go to the ICU, maybe they're on the ventilator for a few days, and then they go to the floor and they go home. And that was the world of trauma. But trauma slowly has been changing. We used to call it the tsunami. Now some people call it the white tsunami, the gray hair. We knew that this was coming. And I was only blessed to know that it was coming because I spent some time at the CDC, Center for Disease Control.
Oh, wow. I don't think I knew that.
Yeah, it was a long time ago when I was a resident. And one thing I can tell you about the CDC is they're always ahead of the game. They think so far in advance. And I remember listening to meetings, and I was at the CDC in 1997, 98, 96, 97. And I heard them say, the biggest problem we're going to have in 2050 is the elderly population. And that just stuck in my head for some reason. It just stayed there. They didn't say much about it, but they said it very clearly that will be the problem, blah, blah, years from now. I'm a resident doing research. I'm not thinking about the elderly population. And then I'd hear it again maybe 5 years later. And then it started to be a reality. If you look at data, you can pull up any data, CDC data, World Health data, and the largest growing population are people over the age of 60. And even more than that, now it's over the age of 80.
Wow.
So the largest growing population of people running around the city are over 80 years old.
And they say the number is going to quadruple in the next 10 to 20 years.
It's going to go up to about, the best data stops at 2060, 2050. But I guarantee it's probably going to go up to 2070, 2080.
Well, you hear the music. You remember these segments go really fast. We got 3 more to go. I got Dr. Mangram here in the studio. We're talking G60. We're talking trauma surgery. We're talking older adults. Stick around. We'll be right back.
Now back to Health Futures, taking stock in you. If you have questions about your own or your loved one's future health care, call 602-264-8009. Now, here's your host, Cypress Home Care Solutions, Bob Roth.
Welcome back. You're listening to Health Futures, Taking Stock in You. I'm your host, Bob Roth, and if you're just tuning in, we're in our second segment here. I am pleased to have Dr. Alicia Mangram here in the studio. She's a trauma surgeon and also the founder of G60. And we were talking, when we left off on the first segment, we were talking about older adults. And I just pulled up a stat. I mean, the internet's great.
Yes.
You know, and so by 2050, the global life expectancy at birth is projected to increase almost by 8 years, although we did decrease during the pandemic.
Mm-hmm.
But what they say is the global population of the oldest of old people, age 80 and older, is expected to triple between 2015 and 2050. So we will have, right now, in 2015, we had 126 million people that were 80 or older. By 2050, it's going to be 446 million people.
Yes.
Is that crazy?
Yes.
I mean, that's worldwide, but that is huge data. I mean, we're living longer. And, you know, you've heard about superagers, and you and I were talking about it before. You know, you got all these people riding bikes early in the morning. They're walking on the paths.
That's right.
They're hiking up the mountains like you did at Camelback.
Yeah.
It's a great way of life to be here. But at the same time, I mean, when somebody has an accident, especially when you're an older adult, it's like I shared before, it's like a car crash. I mean, they don't have the responsiveness. Right. And they don't have the agility that maybe a 20-year-old has when you're 80.
Exactly. And when you look at mechanisms of injury, you know, like you mentioned, the car crash, we call it motor vehicle collisions now. But when you look at motor vehicle collisions, you look at motorcycle collisions, and you look at falls, in the exact opposite order is what we see in the elderly. Their number one reason that they have a traumatic event is a fall. The number 2 is still motor vehicle. So they're still driving. And the number 3 is motorcycle. So they're not just driving cars, they're driving motorcycles. And again, we're talking, and when I say G60, I mean people over 60, but it could be 60, it could be 70,
right,
80. When I look at our trauma list in the morning, one of my partners was telling me, hey, we have about 40 patients on the list today. Guess how many are over the age of 60? It's kind of a joke we play. I say, 70. He says, almost 73%. That's pretty amazing.
It
you
is.
know, now that doesn't happen all the time, but we have had to change our whole way of thinking when it comes to trauma. We've had to do a complete paradigm shift. The way we thought of trauma before, we can no longer think of trauma at all in that way. And if you're not prepared, early on when we didn't know, you know, I wouldn't say we were killing people, but I bet we did some things that we were giving tons of fluids to patients, you know, 20 years ago, and just doing all these things that we have to be so precise now, because a young person, you can do a few things and they're going to survive. You know, we used to have a joke. You can't kill him. You just can't kill him. He was here 2 years ago with a gunshot wound. He's back now with a gunshot wound. But an older patient, you really have to have protocols in place. You have to have, procedures in place. You have to have things lined up in such a way that your geriatric patient needs more time and attention. And again, before G60, before when we had young patients, again, like I say, they come in, car wreck, shot, whatever, fixed. You see them and they're gone. Now you find yourself spending time. You have to talk to the family because this is your 85-year-old father. He's, on a ventilator. He fell. Of course, everybody falls off the ladder. I don't know why. It's something 85-year-olds like to climb ladders.
Oh, yeah.
It's just something. I'm going up that ladder. I'm going to fix something. But they fall. Now they've broken their ribs or they've broken their sternum, their chest, and they're on a ventilator, or they get pneumonia. Or they're on a blood thinner, which is a whole nother subject, the blood thinner subject. We'll have to get to that. But now you find yourself not just doing your trauma work, which is, the work that you want to do, operate, procedures, take care of them, but you're finding yourself sitting down, having talks with the family. And that takes up a lot of your day. Mm-hmm. You've got, the son flying in from here, the grandson coming in, and, the wife, or it's a huge discussion. Do we do a trach and a peg? Would they want to be on a breathing machine? And I don't want to use too many medical terms, but it's everything about the way you care for a trauma patient now, in every way, based on the elderly population, has changed.
And it's interesting because you said, I think it was in our last segment, the order of, trauma, if you would, but falls. Are they represent, how many, you said, 73% of those people were older adults, but how many of those older adults were in there because of a fall?
Falls are the number one mechanism of injury in trauma, period. So I wouldn't want to quote a wrong number, but definitely over 50%. Over 50%.
Over 50%.
Over 50% of the patients.
And if those people did yoga and work on balance, right? Come on, Alicia. They wouldn't fall so much.
They might not fall so much, but they do.
They do.
They just and it's not all just I walked and tripped and fell. It's like I said, doing
ladder.
Things that are a little more aggressive, because I'm fairly convinced the more and more that I look at trauma and look at G60 and deal with geriatric patients, their bodies are 70 and 80, but a lot of their minds are 40 and 50. Like my mind was 40. Why did I climb up Camelback? Because my mind, I can do that. That's easy.
Right.
But the body is like, now, wait a minute. You really don't need to do that. Why don't you go swim in a swimming pool and do some laps, do some things that are easier to do, People jumping on motorcycles at 70 and 80. Not that you can't ride a motorcycle, but your reflexes are not the same.
Exactly.
You can't make the moves as fast. And I tell people, be careful riding your bike, not because you're riding your bike, the young people, but we have an 80 or 90-year-old driving the car and trying to not hit you in that little itty-bitty lane that they give them. Find a big bike trail that's wide open, because we see those injuries as well.
There's something that happens when you age, and that is cognitively there's declining. Mm-hmm. You decline cognitively, reflex-wise. I mean, you're right. The mind is, saying, I can go, 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 but your body's just like, no, no, no. Mm-hmm. And I will tell you that personally, I found myself about 3 years ago up on a ladder on that top step that they say don't step on. and the reason why I was up there was I had a smoke detector that was chirping.
Yes.
And I wanted to go to sleep, and literally I was struggling up there, and I looked down, and I mean I'm up like 14 feet.
Exactly.
And I came down the ladder, and my wife Susie came in, and she goes, "What are you doing?" And I said, "Well, I just changed the battery on." And she goes, "You did?" And I said, "Yeah, that's the last time I do that." Yeah. Because I knew that I just, at 60 years old or close to 60, I just could not do that.
Shouldn't be doing that.
Yeah.
Yeah.
And you see a lot of people come in with falls off ladders.
Falls off ladders, falls from the roof. One of the worst times I hate to be around my house is when they come to put up the Christmas lights.
Right.
I'm like, why are you putting up the lights? You got to be 50, 60. Right. Why didn't the 18-year-old go put up the Christmas lights?
Exactly.
Because if you fall, I don't want to be here.
Exactly. The other thing that I want to just briefly touch on before we go into halftime here is that, you put these people back together again. And how do you optimize the recovery in a post-set situation? Do you follow your patients? Do they come back, or do you just give them a referral and then that's it?
So that's such a great question because
and I know we're not going to be able to finish this question, but let's start it and then we'll.
So the
finish
reason
it.
it's such a great question is that's always been one of the things that I've been in the back of my mind and outwardly really, really trying to work on, because I feel like they come into the hospital and we do a really good job of taking care of them. And then we discharge them. And then what?
Right.
Okay, yes, you'll come back and see me or one of my partners who fixed your ribs for, that one-time follow-up. You'll come back and see the orthopedic surgeon for that one-time follow-up. But then what? And where do we go? And so we're actually working on a project that we'll probably have to talk about after halftime that we had started working on. So now I've been working on this project for 4 years, almost 5, because we started it right before COVID. And so there's a company, a group that I've been working with. His name is Tony Dorman.
We're going to end on Tony Dorman,
Okay.
and I know Tony,
Good.
the electronic caregiver.
Yeah.
We'll talk a little more about that in the second half. You're listening to Health Futures Taking Stock, and I got Dr. Alicia Mangram here in the studio. We got one more half. I hope you're enjoying the show. This is your host, Bob Roth, managing partner and co-founder of Cypress Home Care Solutions. If you have any questions about the topics that are discussed during the show, visit us online at cypresshomecare.com or give us a call at 602-264-8009. We are entering now the second half of our show, so stay tuned for more helpful information to assist you with your aging loved ones.
Now back to Health Futures, taking stock in you. If you have questions about your own or your loved one's future health care, call 602-264-8009. Now, here's your host, Cypress Home Care Solutions, Bob Roth.
Welcome back. You're listening to Health Futures, taking stock in you. If you're just tuning in, I got Dr. Alicia Mangram here in the studio. She's a trauma surgeon, and she's also the founder and CEO of G60 Trauma. And if you missed that first half, go up to our website at cypresshomecare.com. Click on the media button right below is the radio show. You'll catch this one and many, many more. So when we left off, Alicia, we were talking about, okay, so what happens after they come in? And, what are you seeing in terms of a post-type program for these folks that have had these trauma injuries, mainly falls? And
Right.
you started talking about the G60 Blue program.
Mm-hmm,
and
mm-hmm.
you mentioned someone that I know, Tony Dorman,
Mm-hmm.
the electronic caregiver. And,
Right.
and it's not just electronic. He's doing some really clever things.
Oh, yeah.
And by the way, I saw that he made the Inc. 1000 list in terms of growth. So
Yeah, he's growing. I'm sure he's growing like crazy
oh, yes.
because he's got something to offer, that people need. They say if you're doing something that provides a solution then to a problem, then it'll do very well.
Well, he's been around a while,
Yeah.
and you mentioned at the end of our second segment, right before halftime, you mentioned that this has been like 4 or 5 years in the making.
Mm-hmm.
No thanks to COVID, because you would be a lot further along. So now you're back up and running, and he's actually got some interesting new tools and new equipment since you started before COVID. So I want you to take us through what this G60 Blue program is.
So it's interesting how I met Tony. My research director, his name is James Zandu. I would talk to him a lot about, I wonder what happens to our patients when they leave here, because they're not young and going back to work. Do they all go to, some nursing home, or their parents stuck, or their children stuck taking care of them?
Mm-hmm.
That we never really do anything about, what happens after the hospital care. We just provide good care and leave. And then he, of course, said, I want to introduce you to someone. He introduced me to Tony. And Tony was telling me about his electronic caregiver. And I really got excited about it. And that was probably 2018. I said, wow, this is great. I said, all the things it can do, and it was still in developmental phase.
Mm-hmm.
I mean, we were talking about things like Addison can maybe help the patient do physical therapy at home. Many of them can't get rides, and it can give them, medication reminders.
And just for our listeners, so they understand, Addison's a virtual caregiver.
It's a virtual caregiver.
Yes.
So we're talking AI now.
Right.
So it's a virtual caregiver. And of course, I liked it because it was kind of like not an iPhone, but it had all the bells and gadgets, and it looked good, and you could make.
It's like science fiction.
Yeah, just fun
so
stuff.
Cool.
And,
yeah.
It's like, say, hey, Alicia, it's time to take your medicine. Alicia, it's time to do your yoga. It's time to do your physical therapy. It was just aftercare, and then it provided the ability for them to have 24-hour access to physicians. And, all the things that are really hard to do, even if you haven't been in a trauma.
Mm-hmm.
Right? So now imagine you've been in a trauma,
right?
And you got to get to the doctor, or do you? You need your medication reminders. You need to do your physical therapy. And I just pictured that this would be a really, really great segue from G60 to a program that we would call G60 Blue, that would provide all the things that you need, the things I've already mentioned, but in addition, your health monitoring, monitoring all the, blood, your glucose, your blood pressure, your heart rate, maybe be an early detector of something that's about to happen, notify you if you've fallen and you need help getting up, even though we have a lot of AI that does all those things. But your family can have you like on their phone. Let me see what Mama's doing. Mom, it looks like you didn't take your medicine. You didn't do this. You didn't do this. You didn't do this. So we wrote up a really big protocol to see if this will decrease mortality, if it will decrease readmission rates to the hospital, which is a huge thing, and just overall, we were going to look at patient and caregiver satisfaction. Wrote up a protocol, had it all in place. It was in the IRB phase to see if it was approved, and then COVID. If you
don't mind me saying, because we throw around all kinds of acronyms. What's IRB?
It's an internal review board.
Okay, good.
That approves studies.
Thank you.
But then COVID came, and so it was immediately stopped because who's going to go into the home to even set it up in an elderly patient? The physicians to do the study, we were going to go and see about their satisfaction and how it worked. But all of that stuff stopped. We couldn't go in patients' homes. We couldn't do those things. But now we're bringing it back. People are a lot better, more comfortable with you coming into their homes, more comfortable with getting the program set up. So we're going to do a pilot study. And so we've actually written a protocol for the pilot study. It's just going through its budget phase and going back through the IRB to get approved. So all those regulatory things are being done. And really we want to make sure that this is something that's feasible. Again, does it decrease readmission rate, patient and caregiver satisfaction? Because that's what we're finding is huge. When when I had my hip fixed, I'm back up and walking, that day really. But if I were 80, what am I really doing? And who's helping me?
Right.
Who's there? Because kids have to work.
Right.
And if you're 80, your kids are probably, 40, 50, maybe 60. But, we need something for aftercare. So that's been a huge, I don't want to use the word concern, but something that's always just disturbed me. How can we do better than just in the hospital? And I think you're gonna see this come to fruition. Which AI device, I don't know. I can tell you the one we're working with is the electronic caregiver. They're doing some amazing things. They have these different avatars that they're creating. They even have things that help with depression. Like would you like to read a book together, or Addison talks to you, and they started with Addison 1. Now they're at Addison version 11. It's like iPhone. It keeps getting better and better and better. And so that's kind of one of my second sort of big goals is what can we do to improve care after? I'm not trying to be a medicine doctor,
right.
But I'm trying to help put a program together that medicine doctors can help with that provide things at home for patients after they've been involved in a trauma.
Well, definitely we'll want to talk more after the show because we're doing something with artificial intelligence in the home.
Good.
And you know, the one statement of fact that I want to share with you, and you may or may not know this, that we as a country have a lot of solo agers.
Mm-hmm.
We're talking about nearly 30% of our population, 65 and older, lives home alone.
Mm-hmm.
And, you know, having virtual, having artificial intelligence, having professional home care agencies like ourselves, friends or neighbors are always welcome too to help these people age, especially when you've discharged them after you've put them back together again.
Exactly.
And like you said, they'll come in for their follow-up visit, but then what happens from there?
Right.
Yeah, so it's giving them the tools.
And that's why the skilled nursing facilities, we call them SNFs,
Yes.
probably 80% or more of our patients have to be discharged to SNF because they need more time to just get back to doing, you know, natural things, you know, just going to the bathroom, taking a shower, all their daily activities of life. So, and they just can't go from the hospital to home. So it's going to be very interesting when we do this study because we're going to start with patients that go from the hospital to home and see, you know, how well that works out. And if it does work out, I envision a bigger study for patients that go home with home health. So, because home health only comes and, you know, stays for whatever amount of time
Episodic.
they're allotted, right?
Yeah, 45 minutes, an hour.
Right, whatever.
Yeah.
But they can make sure that they're using the AI, the electronic caregiver. Make sure, you know, check those things out. Make sure the vitals are all, you know, not just the vitals they take while they're there,
Right.
but the trend of the vitals. You know, the trends of how much walking you're doing, the trend of your physical therapy. So I think we're going to have to grow in some way, and this is the way that I see
100%.
us growing.
100%. I mean, with these solo agers, and by the way, you know, Dr. Joseph Coughlin from the MIT Age Lab says by between 2040 and 2050, that number is going to hit 50%.
Oh, absolutely.
50% of our 65-year-olds and older are going to be home alone.
Yeah.
And virtual caregiving, having professional home care agencies, having people come into the home is going to be vital for us to be able to have people age. I use the word successfully, and I've been criticized by, you know, one doctor over at ASU. He's a professor. He says, "Who ages successfully anyway? Everyone has deficits, you know."
Right. We fight over simple things like a geriatric patient versus the older adult.
Right.
Or, you know, whatever term that you want to use to figure out. The bottom line is we are all going to age, and it looks like we're going to age a little more healthy. And by healthy, I mean we're living longer.
Well, I'll tell you what, we're done our third segment. We got one more to go, and I want to talk about, you know, where some of the G60 programs can be found. I know you have some partnerships, and partnerships are critical to our success. I've always said that, you know, innovation takes collaboration, and you're collaborating with a bunch of partners, including the electronic caregiver. But I also want to talk about, you brought it up before, medications like blood thinners and stuff.
Absolutely.
What that means.
Yeah.
You're listening to Health Futures, Taking Stock in You. I'm your host, Bob Roth. I got Dr. Alicia Mangram here in the studio. Stick around. We got one more segment. We'll be right back.
Now back to Health Futures, taking stock in you. If you have questions about your own or your loved one's future health care, call 602-264-8009. Now, here's your host, Cypress Home Care Solutions, Bob Roth.
Welcome back. You're listening to Health Futures, Taking Stock in You. I'm your host, Bob Roth, and if you're just tuning in, we're in our last segment here. I have got Dr. Alicia Mangram. She's a trauma surgeon. She's also the founder of G60 Trauma. And if you missed our first three segments, go up to our website at cypresshomecare.com. Click on the media button. Right below it is radio show. You'll catch this one and many, many more. So when we left off the third segment, I kind of teed up this one. I wanted to talk about two different things. I want to talk about partnerships because you have some partnerships with the G60 Trauma, not-for-profit that you've created. And I also want to talk about older adults and the medications they take, specifically blood thinners and possibilities of falls. So whatever order you want to tackle them in, please do. I want to touch on those things because I think they're very relevant for our listeners.
Okay, very good. My microphone's kind of going in and out. I guess you can hear me, though.
I can hear you, yeah.
Okay, very good.
It's probably just your headset.
Yeah, okay, very good.
Okay.
So let's tackle the blood thinners. Let's tackle blood thinners. And the reason it's so important is because, one of the biggest things that we see when people fall are hip fractures. Okay? But one of the biggest injuries that causes mortality or death are traumatic brain injuries. Okay, a lot of when patients fall and they experience a traumatic brain injury, which is a significant number of patients.
Right.
That sort of changes everything when we think about the care of the patient. And when you think about a person who falls and has a traumatic brain injury, we're thinking about they bled somewhere in the brain. And we categorize it, and I won't go into details with that, but whether you bled, and you outside your dura or in your brain itself. And again, I don't want to give too many, like epidural, subdurals, but let's just say blood in the brain. Okay?
Blood in the brain.
Blood in the brain. So
right.
You have you fall and you have a traumatic brain injury. And one of the things that we're facing is what blood thinner are you on? Because patients over 70, 80, 90, I don't remember the exact number, but over 50%, again,
right,
are on some sort of blood thinner.
Heart disease is the number one killer of people.
That's right.
Still is.
They're on these oral anticoagulants. We call them DOACs, but you can look them up. There's all kinds of names. There's some similar ones like, heparin that gets changed to warfarin. Warfarin is kind of a big one.
Right.
Aspirin is the biggest one. Everybody understands aspirin.
Right.
And when you look at patients that have a traumatic brain injury, and it's been studied a lot, and I was recently involved in a study where they looked at, okay, what's worse? Is it aspirin? Is it warfarin? And warfarin, you have to have your blood levels checked, and that's why the new blood thinners came out, so that you don't have to have
Is warfarin Coumadin?
Warfarin is Coumadin, yeah.
And then there's Eliquis, too.
Yes, yep. And there's Eliquis, too. And the Eliquis, you don't have to have those levels checked. And so that's easier than going to a doctor and getting your blood level checked every 3 days. And then aspirin is aspirin. And there's a lot going on with aspirin now. Is 81 milligrams really what people need? Is it 325 or 375 milligrams? So there'll be a lot more coming out when it comes to blood thinners. But just everybody should keep in mind, if you fall and you hit your head and you're on a blood thinner, you need to go to a trauma center. And it's very important.
Can you say that again? Because people do take falls, and
right.
I want our listeners to know this because, when you ask the person that took the fall, "Are you okay?" Invariably, probably 99%, they say, "Yeah, I'm fine."
Yes, absolutely.
But please repeat that and tell our listeners why this is important.
And so this is so important. If you fall and hit your head, like you said, most people, I'm okay, just, got a little scratch, cut my head, and you're on a blood thinner. And some people think, well, I'm just on an aspirin. That aspirin is not going to cause that big of a problem. I'm on warfarin, a little more concerned.
Right.
I'm on Eliquis, or I'm on some, direct oral anticoagulant. You should go to the hospital. This just happened to me this week. I had a friend hit her head, big scratch, and didn't want to go. And what we found is, though sometimes when we find a TBI, traumatic head injury, traumatic bleed in the brain, we have to watch it. Brain bleed. Keep it simple. Those patients need to be watched. We need to repeat their CT scans because we've seen evolution or increase in size of that brain bleed on all of them. But believe it or not, we've seen more on aspirin. In one of the studies that just came out, it's going to be published soon in the American Journal of Surgery. Aspirin, believe it or not, was a pretty strong indicator of worsening brain bleed. Now, when they broke it out and looked even deeper, then warfarin had a high rate of brain bleed, which is surprising because we as trauma surgeons early on think, Well, I hope they're on warfarin, Coumadin, because I can reverse that. And there were some drugs that you can't reverse. So if I were going to stress anything, if you fall and you're on a blood thinner and you hit your head and you had a pretty significant head hit, just go to the ER.
You don't need to get in an ambulance. Just have someone take you to the ER and get checked out.
If you're moving everything, if you're neurologically intact and you can drive, yes. But if there's any deficit, just call 911.
Exactly.
Call 911. And the reason to call 911, if there's any concern, the trauma team gets activated and you get taken care of significantly quicker.
Nice. No,
Yes.
and so good to know. So we have about a minute left.
Yeah.
So I want to just real quickly ask, you have partnerships with G60. Where do we find those?
Well, partnerships with G60 is like partnership with trauma centers in the hospital.
There you go.
I've traveled to probably 30 states and given G60 talks,
Oh, wow.
G60 recommendations. I'm going to be working shortly here with the state of Georgia. They asked me to come and help them with
Nice.
some protocols with G60. So G60 is going to always grow until 2050, 2060. We'll keep finding ways to do better.
I love it.
And
It's ubiquitous.
yes.
The goal is to have it everywhere.
That's true. That is.
So, Alicia, as we wind down, is there a question I haven't asked, or is there a lasting thought or two that you want to leave our listeners as we wind down the segment and the show?
No, I would just say, this is a very important topic. Pay attention to people that are elderly. If you're elderly and if you're getting older and things are getting a little harder to do, don't try to push it. Try to do what you can do, have fun, enjoy playing golf, stay healthy, walk, do all the things that you can do. But if you get hurt, you should go to a trauma center. You really should.
No, I think that's sage advice, and certainly, you don't need to go hit the gym and pump iron.
No.
You can do Tai Chi, you can do yoga,
That's
you
exactly
can
right.
move and walk, like you
Grow
said.
old gracefully.
I love it.
But the trauma centers are here for you. So just remember that. Go to trauma
Dr.
center.
Alicia Mangram, you look great.
Thank
I can't believe you had a hip replacement and you just hiked up Camelback Mountain.
It was about 8 months after,
But we did share your plans for the weekend, so there may be hiking in your plans for the
There may
weekend.
be.
So I
There
really
may
love
be.
that. I loved having you here on the show.
same
Let's
here.
not wait 4 years next time.
No, and hello to your wife for me.
Well, thank you. You make it a great day. Have a great weekend. We'll be back next Friday. Thank you, Dr. Alicia Mangram.
You're very welcome. Thank you.
There's no place like home. You've been listening to Bob Roth's Health Futures. If you have questions about your own or your loved one's future health care, call Cypress Home Care Solutions at 602-264-8009. That's 602-264-8009. Or visit cypresshomecare.com. Be sure to join Health Futures with Bob Roth every Friday at noon, right here on Money Radio 1510 and 105.3 FM.